8 o'clock. Okay, let me share my screen. See if I can do this. Boom. All right, good morning, everybody. Welcome to the San Francisco March chapter meeting. The screen is killing me here. All right, besides Fax, who's a gold sponsor, is there any other gold sponsors on the call? Granger, I know Tom's on there, he's driving, but thank you. TJ, I don't know if you guys are gold yet, but
we're moving on up. We're silver right now.
All right, great. Thank you for being a sponsor. Shane, I know that you're on the list as well for silver.
Yes, sir.
Thank
That's
you.
okay. TJ's got a heart of gold, so he's a gold sponsor.
All right. If there's anybody else I missed, I apologize. My screen, I can only see a couple things. So moving on to executive update. We do not have an executive on board with us today for an update, but they did send out the e-bulletin. So if you had a chance to read that, there's some good information. Energy to Care, President Narshima's report. I thought he had some pretty good content in there. Moving on to upcoming calendar, Rose.
Yeah, so our next meeting, April 28th, will be the HCAI hospital seismic update. And then our fun vendor show at the Italian Club in Oakland on April 27th. And then our annual institute at Squaw Creek, June 1 through 3. And then our wonderful golf event at Blackhawk. Please check your mailboxes tomorrow for the registration.
Yeah, that's been 2 years coming, so we're glad to get back on the golf links there. All right, going into chapter business, just to give you an update. Rose has been working extremely hard behind the scenes. Thank you very much. We're looking at doing a holiday cruise for Christmas time, so that's going to be exciting for holidays. And we're really excited about the Fratellanza event. So that'll be our first in-person meeting. If you all can join, come on out. It's a great event. We have food, some great vendor tables to walk through, meet everybody. So come on out. It'll be
Angel,
in Berkeley.
Angel, did you guys start taking tables for the vendor side of the Fratellanza date?
Yeah, I believe Mike's going to start making calls this week. We just got approval, so
Okay.
you'll get a call from that.
All right, put us down.
Awesome. All right, and with that, I'd like to go on to our presentation. Today we have Forensic Analytical Consulting Services, FACS, who's going to be doing a Joint Commission ECO 20502 water management presentation to us. Would like to introduce John Martinelli and Madeline Rubilba. Did I pronounce that right?
Revelita. You get closer. Yeah, I got married and had to learn a new name. Sorry about that.
Okay, I'll stop sharing my screen, Madeline, so you can do it.
All right. Can everyone see my screen?
Yeah, you might want to flip the display settings because we're seeing your pre.
There we go.
Okay. All right. I am going to hide my floating media controls because it gets in my way. All right. Well, good morning. Thank you, Angel, for the introduction. As you know, there is a new Joint Commission standard out surrounding water management, and there was a previous EC. We'll talk about some of the differences in those. I'll go over introducing myself. Sounds like more people are familiar with John, but we'll go over a quick introduction there just so you have a little bit of background. We'll do a sort of a broad overview of what's new and different about the EC, sort of a little bit more of a deep dive into the documentation, and then John's going to finish up with discussing the role of the water management team, the agency guidance and interpretation, because there's also been updates in standards and guidance. And then we'll go through some Q&A, and John's going to talk to you about a very important thing, contingency planning when it comes to different types of activities in the healthcare environment surrounding this particular EC. So everyone knows who John is. He's basically like a famous rock star in the world of CSHI, but John has been with Forensic for, I don't know, 30 plus years. And he has a lot of expertise in healthcare. He's our healthcare practice director and one of our principals. So we're very lucky to have him with us today. I've been with Forensic since 2016 and I work as a senior project manager now. Recently went through this new ASSE IAPMO Legionella Water Safety and Management Specialist certification training. We'll talk a little bit about that too. And I started at Forensic with like sort of a really broad brush, doing hazardous building materials, mold and moisture, and since then have really kind of narrowed my focus into working in waterborne pathogen management programs and outbreak investigations in a variety of settings. But to be honest, my favorite is hospitals, and I love working with hospital engineers. So I'm very excited to have a captive audience today with you guys. So we do have 4 different learning objectives for this presentation. I typically don't read all the words on a slide, but I'll talk a little bit about these. The first objective is to understand and be able to describe these 4 core elements of this new environment of care standard and how that differs from the previous one, which should be easy because the previous one was literally 1 sentence. The second one is to discuss the type of documentation that's required, how you complete it, maintain it, review it, and revise it within the context of your water management program. Third one is to describe the role of the water management team in maintaining, reviewing, and revising your program documents, as well as any kind of event-oriented responses. And that's a little bit about what John's going to be talking about. Last one is to review and discuss the role that these specific agencies have and where they're referenced in the new standard. So that's the Center for Medicaid Services, CDC, AIHA, and ASHRAE. So this new standard went into effect January 1st. They did release this pre-publication requirement, so we all got a little heads up in advance. It applies to hospitals, nursing centers, and critical access hospitals. And it exists, as we know, because of the CMS memo that came out in 2017, 16, updated in 17. And it reflects the directive that all healthcare facilities need to have some sort of water management program. And that memo references CDC and ASHRAE. This new standard also references CDC and ASHRAE. And then it does recommend this new thing called a WICRA. Some of you may have already conducted a WICRA, but it's a water infection control risk assessment. We'll talk about that too. So here's the old EC. It says you have to manage risks associated with your utility systems, and the element of performance for that is to minimize biological pathogens in your cooling towers, your domestic water, and other aerosolizing systems. It doesn't even say you need to have a plan or a program, right? It just says you have to minimize this and gives no further description. The updated version is much more descriptive, but weirdly non-specific in some other areas, and we'll talk about that too. But this one says that you have to have a water management program for Legionella and other waterborne pathogens that follows law and regulatory guidance. So law and regulatory guidance, John's going to talk more about this, but you know, we know CDC is not a regulatory agency. ASHRAE is not a regulatory agency. The Center for Medicaid Services created this directive, and that's where this standard was born from. They're referencing these other things. So I just want to make sure as we go through this, there's a lot of like, well, what do we have to do and what do we not have to do? There's things that are strongly suggested and will help you try and negotiate those pathways. Also, the ASHRAE guidance has been updated recently within the last 2 years. The Cooling Tower Institute guidance was updated recently. The CDC put out new updated documents. So important to know that you want to be looking at the most updated version. So the first element of performance for this is that you need to have an individual or team responsible for managing the program, including the development, management, and maintenance activities. So this is your water management team. This is your water management team lead. And that's a lot of stuff to do, as I'm sure you guys know. And we'll talk in more detail about the water management program team, but it's really important how you select that team, and that it's individuals that have the knowledge, the authority, and the bandwidth to take on this program element. So the second element is that the water management program or the water management team needs to develop the following. First thing, a basic diagram, essentially a process flow diagram that maps out your water supply sources, your treatment systems, any processing steps, control measures, and end use points. So I'll talk a little bit more later about the order in which they put these out. It's a little confusing. Typically, we do an assessment first to develop controls, and they talk about controls first here. When you look at the CDC toolkit, they have an example of a process flow diagram, and they put these little icons on there to show what the control measure is. You don't have to do that. That's how we kind of build out our programs, but that's why you see that little picture there. So you have to map out and understand how water moves through your facility and determine what those control measures are. They do give an example here that it could be a flow chart with the symbol showing the sink, showers, water fountains, ice machines, and so forth. They're talking about every single end use point. It's challenging to put that on one page, right? So just something to think about when we look at the documentation piece. Then they want you to include in that diagram a risk management plan that includes the evaluation of the physical and chemical conditions to identify any potential hazardous conditions. We call this hazard identification. So there's sort of a corresponding symbol for the, let's say our control is we're monitoring temperature, and we're doing that because that particular area, piece of equipment is temperature permissive. They also specifically call out conditions where there is slow or stagnant water. And here's where they make their reference to the WCRA. It's a note. It says, refer to the CDC WCRA for healthcare settings tool as an example for conducting a water-based risk assessment. And they have this fillable PDF. I found it a little clunky when I tried to use it. I don't know, we can talk in the discussion if anyone else has done it, how you've gone about doing it. But essentially, it's a facility risk assessment focused on water and specifically around looking at patient populations. I don't want to draw your attention to that just yet. So the next thing they talk about is having a plan for dealing with areas where there is low use. So having some sort of flushing program. And then an evaluation of the patient populations, which that occurs during the WCRA. And then the last thing they talk about is having monitoring protocols and acceptable ranges for your control measures. So if you're monitoring temperature, what's the target range there? Then they have this note. And the reason I highlighted it is because in the previous CDC documents, they don't specifically talk about monitoring pH, but the pH of water can impact the efficacy of certain disinfectants. So I just want to point out that they do talk about it here. So if you're not currently monitoring pH, you can consider adding that as part of your protocols. Importantly, you want to make sure that your protocols here specify the parameters that you're measuring, where you're collecting the measurements, and what your corrective actions are when those are out of range. Okay, third one. The water management team needs to document the results of all monitoring activities, corrective actions, procedures, what you do if a test is out of range, and including when you are doing any kind of sampling for waterborne pathogens. How are you interpreting that, and what is your corrective action? They talk a lot about documenting corrective actions here. So it tells me, I don't know anyone who's been inspected yet under this new standard. I know someone who had a mock survey and they did well on it, but I don't know how this is going to look. So if you didn't write it down, it didn't happen. Basically, that's the end of this. So, and it's not just about, saying, yes, we do these things. How is the monitoring documented? Are you doing it through your work order system or your PM system? What are your acceptable ranges? What are you going to do if it's out of range? And where do we keep all this documentation? Who looks at it? I mean, it's a lot, right? It's not just a piece of paper. There's a whole process for it. Fun, right? Okay, so the last one here is that the water management team needs to review the program annually. So you're already having probably quarterly meetings, having at least an annual meeting. They don't talk about quarterly meetings here too. That quarterly meeting is part of the CDC guidance, but an annual meeting here to discuss if there are any changes that have been made to the water system. So say you're doing construction, interrupting a water main, something like that, installing any new equipment that may potentially be aerosol generating, commissioning of a new wing or building. And then there's two notes here. Here's where they talk about the CMS memo. So note 1, the Joint Commission and CMS do not require culturing for Legionella or other waterborne pathogens. So determining when to sample and what your testing protocols are, that's at the discretion of the hospital, unless it's being required by one of the authorities having jurisdiction or in some sort of outbreak situation. The second note here references the ASHRAE 188 document. Here they call out 188-2018 because this was the publication standard, and the 2021 version wasn't out yet. To reference that, as well as the CDC toolkit for any additional guidance, as well as the ASHRAE ANSI guideline 12. That's sort of like the practical application of how we're going to implement this program. I had cool animations, you guys. I didn't even click them. All right. So I put those up there just to know these things have been updated recently. Okay, so let's get into documentation. Everyone's favorite thing. John, did you want to add anything to that section before I move on?
No, I think you're going just on target.
Okay, great. Thank you. So when you're looking at the standard, at least for me, I kind of needed to pull it apart and try and simplify it a little bit because it felt sort of herky-jerky and out of order. It felt a little bit overwhelming. And I see this when I develop these programs, and I always feel a little bad because I walk in and I hand you, here's this massive document, and here's a new like 40-hour-a-week job for you, at least for the first year, right? It's a lot to do, and it can feel really overwhelming. And sometimes when we get a little overwhelmed, it's like we just sort of, it's a little paralyzing sometimes, and very, very, very frustrating. You guys already have way too much on your plate and not enough bodies to do all the work that you have to get done. So in an effort to kind of simplify this, I eliminated the notes part and just kind of called out the things they specifically say. I didn't reorganize anything. I kept it in the same order. And then I looked at an existing water management program. And I've been working on these programs with John and other people from our team since the CMS memo came out. And so ours started as this incredibly detailed, complex thing and has since been refined down to what I feel is a little bit more accessible and practical space that still covers the areas that are specifically talked about as far as industry best practices, as well as what is required by law and regulation. And then I linked it to, so each one of these elements of performance, I created this rubric so that I could see where it shows up in our program documents. The intent for this is to have it be something that I can give to the inspector. So they know when they're looking, well, where in your program documents do you talk about, your risk management plan? So I can point them to that specific portion of the written program, as well as any supporting appendices or documentation. So this is just sort of like a little one-stop shop for how we're going to decide exactly how we want to organize the program in the program document. There is no, and I'll back up just a minute here. You see this little boop, boop, the D there, so I'm looking at where they're requiring documentation. There is no documentation required for this number one. It just says, you don't have to have any piece of paper that says who's on the team, right? But I think it's probably a good idea to have that just so you know, right? But that's not a requirement. So I talked a little bit before about how it felt sort of out of order, where we're looking at control measures first before we look at the developing any kind of hazard control plan or doing any kind of risk assessment. In ASHRAE 188, to put this in context for you, they look at this in a different order, okay? So the first thing you need to do is understand your building plumbing system. Okay, they do talk about that in the EP. Next, you do your risk assessment. Based on the risk assessment, you identify where you have any high-risk areas of equipment, identify hazards that may be associated with that equipment within the context of Legionella. And then from there, determining what your control measures are. And then within each one of those control measures, having a standard operating procedure, developing your specific protocols. So your target ranges, corrective actions, et cetera. And then all of that combines to create your hazard control plan. The way that the EPs look, the first thing they talk about is doing the process flow diagram, but with control measures. Then they talk about the risk management plan with hazard identification. Then they talk about one specific hazard, low use fixtures and components as part of your management plan. Then the risk assessments come in kind of late in there, and then having protocols for controls. So I don't want to confuse you with this. There is a logical order in which we go about developing these programs. And following ASHRAE 188 will still get you to where you need to be in compliance with the standard. That made sense there. We can talk about it in a second, or at the end of the program. So here's an example of a process flow diagram. This is a lot, right? It looks a little busy, but it's a lot that they talk about having on there. So rather than calling out every individual end use point, I'm just saying restroom sinks on the first floor. And then I have my control measures here that indicate what we're going to be looking at in those specific areas. It's broken down into how the cold water is processed and received and distributed, how the hot water is processed and how the hot water is distributed. In the CDC toolkit, they do call out having that, that waste piece as well, from an exposure standpoint. Knowing where the water exits the building and goes into the sanitary sewer doesn't seem super important, but it is called out in that document, so it's just something to be aware of. It's just one extra box to put on the page, I guess. And then here's what the hazard identification piece looks like. So we're looking at, our top offenders here, right? Things we're concerned about making mists, like cooling towers, showers, temperature permissive areas like maybe birthing tubs. If you have any decorative fountains, just stop, get rid of those, please. Any construction, and then looking for, biofilms, corrosion scale, and where there might be water temperature fluctuations as well. This is another example of a process flow diagram. This is what if you're lucky enough to get a brand new building and a good architect, you will get this beautiful process flow diagram with your riser diagrams. And boy, when I find these, I'm like, thank you. It's like gold, very rare. So, but this is just one way to kind of call out looking at how the water moves through the system. Now, if you have a surveyor who doesn't really understand how to read plumbing diagrams, it's not that helpful, but they may just look at it and be like, so this is just a detail of that. so when we go in and we develop these programs, this is what I'm looking at to understand how your system. And then I talk to the engineer that's been there the longest, and I learn all the little gremlins and all the little pieces, like this is actually not how it is. So confirm, trust but verify. So distribution diagrams are not specifically called out in the element of performance, but they are talked about in ASHRAE, and it's something that we include in our program documents. It's really helpful if when you're trying to determine where to do monitoring for temperature and disinfectant. If you're going to be doing some validation sampling, it's helpful if you ever are dealing with an outbreak situation to understand where your near and distal locations are, how the plumbing moves through the system, because if you get a result at one part of the system versus another, it can change sort of how we as consultants are trying to identify potential source. Now, it is labor intensive, and so it is a resource heavy, resource dependent activity, but just something to think about. You'll also see on this diagram, we've highlighted where the high risk patient areas are. So our OR, PACU, medical ICU. Again, I find these really helpful when I'm going out to collect samples, so I know exactly where I'm at and what I'm doing. I can put those sample results in context. Looking at control measures, I won't go too deep into the science of Legionella, though I would really, really love to. I think we're all on the same page here. It is a bacteria, it is a water pathogen, it is endemic to water. We expect to find it in low-level concentrations, but there are places where it prefers to grow. And it's really centered around areas where there's low use or stagnant water. If the temperature is within this growth range that is permissive for Legionella and other waterborne pathogens. If there's little to no disinfectant, so you get disinfectant from your municipality, or you may have a secondary treatment system. And then where there's scale and corrosion or biofilms, those are areas where you're going to be seeing a higher risk of a higher level of vulnerability to growth or amplification. Flushing, if you're going to be doing flushing as your control measure, certainly you need to document it. You need to know how to do it, who's doing it. So is EVS responsible for the drinking fountains, and then engineering is responsible for the hose bibs? How is this getting broken down? And if so, making sure everybody's on the same page with the why behind the what, not just the how. How often are you doing it? What's the corrective action? So with flushing, a corrective action, maybe if they notice there's really, really low flow at some point. So say EVS is flushing and they see there's really low flow, or maybe it looks like there's a bunch of scale or corrosion on there, making sure they understand they need to notify the appropriate party to correct that. Providing additional training if needed. As part of the monitoring, making sure, really important, if you are monitoring for disinfectant, how you're doing it. Are you using a colorimeter? Are you using strips? Making sure you're using the correct method. Any equipment you're using is being calibrated, and all of that's being documented. And similar to the flushing program, how often are you doing it, and what are those corrective actions? So if you're collecting, quarterly temperature and oxidant readings, but you're not really, you're just sending them out, writing them on a piece of paper, and the piece of paper goes away in a binder, but no one looks at it to determine whether or not they're in range. And even more importantly, are they correcting it? Are they documenting that they have done something to, manage this? So thinking back to that slide from ASHRAE 188 on the process of developing a hazard control plan, right? So we have our risk assessment, hazard identification, control measures, and then we put all of this into one big hazard control plan. I'm sure you're seeing now there's a lot that you need to be thinking about within each one of these pieces. And we make every effort to simplify this program and make it accessible, but it is complex and it is detailed. And at some point, we just have to kind of embrace the details and understand that over time, it will become less overwhelming and just bite off small pieces at a time. The hazard control plan describes all the things we just talked about. And it's kind of like a little, just like the rubric was the one-stop shop for the surveyor, the hazard control plan is kind of the one-stop shop for the water management team or the individual who is responsible for overseeing all of this. And it captures either the detail itself or the location of where we can find this thing. So it's capturing your hazards and your risk rating, what your control measures are, target ranges, how often it's done, how frequency, who does it, and then in our program, we've added in some regulatory and guidance references as well. So if I'm the person responsible for maintaining this storage hot water heater, for example, and I need to know the why behind the what, or I need to reference something, those references are right there. Okay, so the WICRA. Conducting the risk assessment is really important. You can have consultants come out and conduct a facility risk assessment. You can follow the very excellent AIHA document, which helps walk you through conducting a risk assessment as well and do it yourself. And there's also the WICRA here. Now, the WICRA is a little bit more focused on an infection control thing here, right? So it's not just about, you know, looking at cooling towers or hot water heaters. This is really a little bit more focused on patient populations. Individuals that are most vulnerable when exposed to Legionella and other waterborne pathogens are, you know, people that you're going to find in a hospital, older people, people with underlying conditions. The WICRA is an 8-step process. It looks at water sources. It looks at modes of transmission, patient susceptibility, exposure routes, and then how well prepared your program is. And similar to the PICRA, it will kick out a score at the end. And we'll look at this on the next slide, but from there you can, like with the PICRA, you'll get classes of work. With this, there is a way to get classes of control measures. This is all very new. So ASHRAE is the source for this. ASHRAE is the standard for looking at control measures, but just know this is part of it. What does the score mean? So the risk score, it's a high scoring, a high number means that this particular area or water source should have a higher level of prioritization within your program. I don't know. I'll be interested to hear what other groups have done when they've looked at this. I will say this is useful if you're not sure, like, well, isn't everything high risk in a hospital? You know, I think that's some people's reflex, right? Like everything is high liability, high risk. But this does help maybe kind of put that in context a little bit. So it's a helpful tool in that way. So this is the ASSE ANZ IAPMO series of water management and infection control risk assessment for building systems. This is a new standard. It's a certification. There are certifications for consultants like us. There's certifications for engineers, for infection preventionists, for sprinkler fitters. My husband's a sprinkler fitter, and he just got a message from his union hall. They all have to go through this training now. But there's a test at the end. It's a 24-hour course. Test at the end, which is a little challenging, and then it's a 3-year certification. But what they provide in this series in Appendix E, and please, this is, I took a screenshot of it, but you need to pay and take the course to be able to get this and go through it. And I'm also not super thrilled about this particular worksheet, but what it is, it's a WICRA permit. So you can take that WICRA, like a PICRA, and then create this permit from it. And I'd be interested to hear about where you guys think this could be best applied. And I think John's going to talk a lot more about involving the water management team in different events in the hospital. But just know this is a new piece that's out there for the WICRA. Now, the WICRA documentation, you can use this fillable PDF or you can create your own. Doesn't seem to call out one either way. Okay, monitoring protocols and target ranges, creating your specific protocols or SOPs. We took our stuff and turned it into SOPs, and those can be printed out or attached to a work order or something like that. This includes all the important pieces that I've been talking about, making sure that you know exactly how it's done. And then considering adding in the pH monitoring. Just know adding in pH monitoring. Your equipment is only as accurate as the individual using it and the most recent calibration on the equipment, as well as the expertise of the person interpreting the results and the context of those results. So if you add in a pH meter, it's another purchase. There is some maintenance that's required with that. There's calibration standards. So there's a little bit more involved in it, just something to consider. Oh, look at that. I had a whole slide on it. So this is what I was just talking about. If you're using a colorimeter, make sure that your reagents are not expired, that your calibrations are up to date. If you're collecting temperature readings, if you're not using an accurate thermometer, you could, be getting a completely wrong number. So we recommend ASHRAE, and we recommend collecting temperature readings with a NIST traceable thermometer. And that has an every 2 years it needs to get calibrated. They're not expensive. I just buy a new one every 2 years, but rather than sending it in for calibration. And happy to discuss equipment questions at the end here. So documenting corrective actions. This is talked about several times in this standard. So it's something that we really need to be paying attention to as we're looking at these program documents and then preparing for a survey. And also, like, what's the point of having a program if it's, if you're not really doing stuff about it? So what it says in this, in the EP is that the water management team documents the results of all the monitoring activities, including when a probable or confirmed water pathogen indicates action is necessary. Deciding how you're going to interpret those results and what those corrective actions should be is a really important discussion for the water management team to have. And I think John's going to talk a little bit more about that too. How you collect samples is also important, and how they're analyzed, whether it's a sample for, you're culturing for Legionella, or you're collecting disinfectant readings, or say you have a secondary treatment system and you are collecting readings with instrumentation or using an inappropriate method for that particular disinfectant, you're going to overdose or underdose the system. So it can have really far-reaching effects on hospital operations. So that last element of performance is about the annual program review. They want you to do it annually and event-oriented. So if there's any changes that have been made to the water system, construction, new equipment, things like that, the water management team should always be included in the construction and design phase. And John's going to talk about that more, but this is something that is recommended by the CDC, ASHRAE, AIHA, really important to have their input. And you'll learn about that when John does his piece. So how do we document the program review? You could just have meeting minutes and say you did it. I don't know how much detail these surveys are going to want, but if you really want to get into it, what we created was, we obviously love Excel. You can tell by our beautiful, colorful spreadsheets here, but you take that hazard control plan. Remember that one-stop shop, which captured all of those little details or the location of where the little details are. And then use that as your sort of like your table of contents in a way. And have, we created this like worksheet, we printed out big, like 11 by 17, and you just initial. If this is something that's done monthly, you just have a white box for the January spot and initial it. If it's done weekly, quarterly, etc., annually, this is just one way to document it. So you just, when I was talking earlier about how much more robust this standard is, but weirdly non-specific, right? So they say do this, but they don't really say how. And ASHRAE doesn't tell you how to create a form like this. AIHA doesn't tell you exactly how to create a form like this. You just have to kind of work through it yourself and figure out how you want to do it. Or you can, work with another vendor who builds these program documents out. So that's the end of my piece. I'm going to hand it off to John here. John, unless you have anything to add to this.
Nope. Go ahead and
Right.
advance the slide. Next slide. So I will add what Madeline's gone through is the what. There was a lot of what you have to do. And she's mentioned a couple of times that the details are sketchy at best. We've got guidance documents that say you need to manage it. You need to have control measures. You need to have contingency plans if you're out of range for your control measures, and you need to document it. But unfortunately, it doesn't tell you what the control measures are. You have the authority and responsibility to define your own control measures and ranges. And with that responsibility becomes there's potential risk associated with it. So you need to have an effective team. And if you recall, the language says there needs to be an individual or a team responsible for managing the plan. Now that individual is responsible for managing the plan, but there still needs to be a team, in my opinion, to cover all of these things. This graphic is from the CDC toolkit. You need somebody that has the ability to oversee and fund the program. Somebody that has the knowledge of the water systems, that's plan ops folks. The ability to identify those locations and control limits. Ability to identify and take corrective action. That might be facilities, that might be a vendor. Maybe your corrective actions are to install filtration during an outbreak condition. You're going to want to have that contingency in place before it happens. So that in the event you have an outbreak, remember all of this is a prevention program. We're trying to prevent that from occurring. Unfortunately, we've got some competing factors. We'd love to burn the stuff out of the system and push 130-degree water through every fixture, but we can't do that because we've got anti-scalding legislation. We can only go to 120 degrees, which means we're probably going to be below 120 degrees at a lot of locations. We go too far below that number, we're in growth range. In addition to that, we've got high-risk individuals in the building. So even a well-run building, there's still the risk that somebody may get sick. In the event, you're going to respond rather rapidly, and it's going to be emotional, it's going to be urgent, and it's potentially expensive. What you want to do is have your contingency plan in place. If filtration, point of use, or whatever type of filtration you're going to use as part of your contingency in the event of an outbreak, you want to know where you're going to put those filters, what kind of filters you're going to need, and that your filter vendor is going to be ready as soon as you call to be there within 24 or 48 hours and have that stuff installed. So it's not all just facilities folks in this instance for contingency planning. You need to have the ability to monitor and document program performance. That's the validation component. Verification to confirm that the program is performing well. That might be meeting minutes, as Madeline mentioned. And the ability to communicate regularly about the program. Who are the stakeholders? How do you communicate? Where is the communication stored? Does everybody have access to it? That sort of thing. Go ahead and advance, Madeline. Team leads responsible, and I will argue it needs to be somebody needs to be on this team that has access to the funding, because failure to fund is pretty much tantamount to failure to perform. Now, we go through this process and we may have multiple people that are responsible, and that goes back to that hazard control plan. Who owns it, how frequently, and how do they document it? And what about a water treatment vendor? Do you have somebody that's doing secondary treatment on site? What is their role in the process? Are they the ones that are validating that they've got adequate chemistry at all locations? And if you're out of range, what's the response action there? Next slide. As Madeline mentioned, it doesn't require quarterly meetings, but it does require an annual review. Certainly quarterly meetings. This program is designed initially when it came out in ASHRAE 188 back in 2015. It was designed right away to be a continuous improvement program, not a project. This isn't an activity where you do something and then you're done. This is an activity much like the Patient Safety Committee where you're trying to show improvements over time. When we go through the risk assessment process and you use the WICRA, you may have a circumstance where you may have a very high risk activity. That's a high priority. You may have another activity that's not terribly high risk, but it's low hanging fruit. That may be something that you've got the bandwidth and resources in house to take care of it. So you take care of it and you document that you've taken care of it. And now in Q2, something is better than it was in Q1. You may still have a big capital improvement thing that needs to be done. You get that on a plan for the development of the building, and you document that you have a plan for it, and then you execute that plan some point down the road. But this is about checking off action items to show accomplishment. Now it says here again, it does not require culturing for Legionella or other waterborne pathogens. I will tell you that's been the statement that's been around for a long time. It continues to be around. However, in the most recent revision of the CDC toolkit on page F1, you may want to write that down. And that toolkit's free. You can download it online. I just did. But F1 says routine testing for Legionella right at the top. And the testing objectives are to establish a baseline measurement for performance indicators, validating water management plan, evaluating potential growth or transmission sources, confirming success or failure of remedial treatment, and investigating potential sources during a disease or outbreak. And then it goes on to say routine testing may be particularly beneficial in certain types of facilities, such as facilities that house individuals with increased risk of Legionnaire's disease. Great. It may be beneficial. It still doesn't say it's required, but it goes on to, I think what we're seeing here is the writing's on the wall. There's going to be testing for Legionella in our future. They even use the term routine in the CDC toolkit. So this is a departure from previous language. Next slide. Some agency guidance and interpretation documents. The CMS memo 2016 and the amendment 2017 requires healthcare facilities of certain type, long-term care and critical access, acute care. It goes on to say all healthcare facilities should have a water management plan. References the CDC toolkit and ASHRAE 188. While the CDC toolkit and ASHRAE 188 are guidance documents, because they are referenced by a standard, I would inherently say they become part of an enforceable standard. You can make an argument that it doesn't say you have to follow 188, but it does refer you to it. So if you're not following that protocol, you better have a good reason. You probably need to be as good or better. The CDC Toolkit 2017, new modules came out last year. AIHA put out a guidance. I'll talk about that document here in a moment. ASHRAE 188, new revision. ASHRAE 12, 2020, new revision. These are useful documents, especially the AIHA guidance. You'll start getting some guidance on control ranges. One of the tricky parts is if I'm going to collect samples for Legionella, what's the standard do I hold it to? Is it greater than 30% positive or greater than 10 colony forming units on any given sample? There is no written standard. That's where the team has to go and talk about what are we going to live with. This is where it gets tricky because you need to have somebody with that expertise on the team. Go ahead and advance the slide. The CDC toolkit has that example flow diagram. It's not healthcare specific. It does refer to those ASHRAE documents. It is a practical guide. It's not a small document. I mean, it's maybe 80 pages, but it's also not 80 pages of burdensome text. There's a lot of graphics that look like this. So it's a fairly easy document to get through. Someone on your team should be familiar with this document, whether it's an outside vendor or consultant or someone on your staff. Next slide. A lot of modules in there. They mentioned routine sampling on page F1. There are individual modules for potable water systems, cooling towers, hot tubs, decorative fountains, and their devices. That's where you can start getting some of that language. Is what do you for contingency planning if something goes out of range? Next slide. 188, again, Madeline's gone over that, how to make a plan. You go through the 8 steps, get a team, get a flow, do your risk assessment, come up with your control measures, contingency plans, verify, validate, continuously improve. Guideline 12 gives you guidance on how to implement it, and it complements 188. There is some overlap, but it's really detailed guidance for a water management team to develop the elements of the plan. So it's a nice guide document to help you build your program. Next slide. This is the AIHA document. Full disclosure, we have a couple of associates at FACTS that helped develop this document that are listed authors. They were not the lead authors or the editors. So references regulatory agencies, gives us current industry guidance specifically about temperature and chemistry, what best practices are for contingency plans, gives you some guidance on how to inventory water systems and performing a risk assessment. This came out prior to WICRA, how to implement controls and verify and validate controls, some of that testing that Madeline was talking about. It's a proactive management. There's some case responses and some outbreak response examples in there that can help you build your response actions should you run into cases. And it defines sample interpretation and response actions. Although it's not a table that says X is good, Y is bad. It gives you guidance on how to develop that interpretation. Next slide. Remember the key takeaways were ASHRAE and CDC toolkit are the gold standards. Really what we're looking at as the things that will tell us where we're going, how to get there. The WICRA is the core risk assessment tool, that brand new tool. It is nice because it is semi-quantitative. What happens is you've got the rows or the columns, and there's some numerical associations with those columns. Is this a highest risk or a low risk area, 1 through 4? And then all the way over to what about the patient risk? What about your preparedness? But it's still somewhat subjective. You may have someone on your team that says your preparedness level is 3 and someone else says your preparedness level is 2. And you've got to kind of come to your own definition of what preparedness means. And then there will be some things that will jump out at you. Holy, my goodness, we've got a 38. We better do something about that. We've got 7 12s. Are there some of the 12s that we can do now easily? Let's get them done, or some of them we'll do later. What can we live with? One of the things that Madeline showed was that PICRA or that WICRA permit that came from the training she went through. I would suggest that's a pretty good construction document. One of the things that we see is contractors trying to understand what their responsibility is under the water management plan. They're going to take 4 West out of service for 8 weeks. How does that impact your flushing regimen? And who's responsible? Does the contractor have to go and flush the faucets and document it? Or is EVS going to come through the construction area? If so, what do they need to know about entry and exit of the work area? So you can go through that ASSE permit process and kind of develop a construction risk assessment to help the contractors be a part of your process. The challenge with water that's different than air, if we're worried about air moving around the building and mold spores getting patients, that happens when we're generating the dust. An impact of a construction project to your water system can have a long-term impact. It's not just while they're doing construction. If they do something that takes your systems out of range for a period of time and allows for amplification, that amplification can be there for forever and can even start inoculating the rest of the building. So it's really important that construction is engaged in the risk assessment process for water systems. I would argue that it's always been the case with the old Environment and Care Standard 020605. It says that you've got to do risk assessment related construction for air quality, infection control, noise, vibration, impact to utilities, and other hazards that affect care, treatment, and services, right? Well, if you're doing something that's impacting utilities, that includes plumbing systems. Just historically, we haven't been this detailed that we now have to be. So Who on your team understands the AHA guidance, the Cooling Tower Institute guidance, what the World Health Organization or EPA are saying, what's NASEM saying, what the control measures are, and what are the best response actions if we go out of range? We know we're going to go out of range from time to time. We're going to have some temperature challenges. We're going to have some chemistry challenges. Janitors' closets that aren't getting used, the faucets don't get used very regularly. We may go do some chemistry testing and find that the chemistry is being exhausted at that sink. Well, our contingency might be, let's flush that sink every Thursday night for 20 minutes, and then we'll test chemistry again on Monday and see how we do. And maybe we over time develop it to where we only have to do it every other week for 10 minutes, right? We got to get that dialed in. But who on the team knows all these things? Generally, we don't have one person that knows all this. And what we've seen quite frequently is the team gets together and they put this program together and they hand it to Plant Ops and say, here you go. Right? And if it's a well-devised, if you've done the program well, you may have the control measures and the response actions in place, but does Plant Ops have the resources to do all of that testing and validation? You've got to establish that early on in your process and get it into your hazard control plan. Next slide. Remember, we've got the 4 elements of 020501. Establish a team, do your risk assessment, not necessarily in the orders of element of performance, but follow 188, you're going to get there. Develop SOPs and document all of your corrective actions. It's really important that you document this and that it's easy to find that documentation. For those of you that have been going through Joint Commission for a couple of decades, you remember early on, it was completely a document process. They would come and they would do document review. Well, then they came up with the patient tracer model where they walk around the building where the patients were and they start asking questions, right? And we've got to be able to answer those questions on the fly. So know where your documents are. Next slide. Remember, look at your requirements. You got to have a written program that needs to be documented, process flow diagrams, hazard control plan, a WICRA or something similar, protocols and SOPs for control measures, and an annual chain-based water management plan review and risk assessment. Redo the WICRA, and ideally show that things are improving over time. Next slide. The role of the water management team is to manage. It's to maintain, review, and revise the management program. Conduct the annual change-based review. Review the plan, the associated documentation. Develop protocols for all the program elements that are compliant, feasible, and aligned with the industry best practices. Determine when and how to sample for Legionella or whatever it is that you're going to do, and how to interpret the sample results prior to getting them. This is very important. There are 2 conditions that are fairly easy. If I collect a sample and there's nothing there, it's kind of easy for me to say we're good, there's nothing there. If I collect a sample and it's really ugly, it's kind of easy to say, oh no, we better do something. But what about the results that are in between? What are we going to do with those results? We need to know that ahead of time. And finally, ensure that we've got a continuous improvement program outcomes. Show that things are getting better over time. Next slide. How does CMS, CDC, and ASHRAE impact in the development and maintenance of your water? And what about AHA? Answers. CMS is the regulatory body. They've got authority. CDC is not a regulatory body, but gives guidance and referenced. ASHRAE, not a regulatory body, but they set standards that are referenced. And AHA is a professional organization that establishes best practices based on scientific research, regulatory bodies, and standards institute. So they give us good industry best practices. Next slide. What if something goes wrong? What are we going to do? If it's temperature out of range, maybe all we do is flush. Maybe we do some adjustments on the thermal mixing valves. That's what the team has to figure out. If it's disinfectant out of range, perhaps it's flushing. If it's a constant problem, maybe we need to look at secondary treatment. Well, again, one of the challenges, we can talk about flushing and flushing being a big solution because it does. It creates friction, it delivers temperature, it delivers chemistry to the fixtures. but it also uses water, and we're mandated to reduce water usage. So we've got another potential conflict. If we've got cases occurring, that's obviously going to be significantly more involved, probably going to have some filtration, maybe a hyperheating regimen, things like that. All of this needs to be discussed prior to implementation. Next slide, please. We want to do the contingency planning when we are planning and designing our program. If we do it after we get results, we may not have expertise. Emotions are going to run high. Urgency increases cost. Defining conditions is now a challenge because we're defining them with other people involved, like the public health department, and we can cause delays in implementation. It's always better to have that stuff during planning and design than after an event. Next slide. That's it. We're time for questions.
Excellent, Madeline, John, thank you for that presentation. I know there's questions out there. I put it in the chat box for everybody. I know we're coming on our time or at time, but Shane, you got a question?
John, Madeline, exceptional value-packed presentation. I was really impressed. I've seen a lot of them, and that was really good. Your comment about testing being imminent. Well, as of January, the state of Illinois now requires Legionella testing for every healthcare facility. So it went started in New York, it's expanding to Illinois, and it's imminent, folks. But my question to you, with the statement that CMS has Legionella and other opportunistic pathogens, aside from Legionella, what other waterborne pathogens should these healthcare providers be aware of or concerned with, and which patient population would they align with? Because you've got two elements of performance, right? You've got multiple pathogens and you have a patient assessment risk. So enlighten me. I'd love your thoughts on that.
That's a great question. I'm going to throw out the lovely consultant answer. It depends on the risk assessment, Shane. There are some that are pretty common. If you ask the infection preventionists, certainly they're going to put Pseudomonas aeruginosa at the top of their list. But we're seeing a lot of others, Acinetobacter, non-tuberculous mycobacteria. It really depends on the performance of the system and the risk of the patient population. Pseudomonas is probably a more problematic organism than Legionella. The good news is what works for Legionella works for Pseudomonas. If we're managing the system, we're managing the system, right? Temperature and chemistry and flow work for everything. Pseudomonas is a little bit more tricky. We're certainly worried about NICU and other high-risk departments. And one of the challenges with that is it can cause infection, not just related to being aerosolized and inhaled or aspirated. It can cause infection due to hand transmission from a surface to a patient. So a lot of times it's not infections, but colonizations that says there's something going on there. And what we see a lot is there are pre-screening of certain patient populations for those bacteria. And so that's why it's really important to have the clinicians on the water management team so that they can look at what trends are happening in their building and say, we really should be checking for this organism as well as others. It's a good question, Shane.
Thank you, John.
Excellent question. And I would echo John's sentiment that it is really critically important to have a representative from infection control and even better, a clinician from infectious disease, because their job is they follow these trends in emerging pathogens. And John mentioned one of them, Acinetobacter. There's Burkholderia cepacia. There's these organisms that then get on the CDC's radar, and your local public health person defers to CDC on everything. And so they're getting, I subscribe to the CDC Emerging Infectious Disease email, which is a thrill a minute, highly recommend. But it's a way for me to say, okay, all right, I'm just going to keep that in the back of my head if this shows up, because it helps me as a consultant maybe make some, anticipate the potential level of involvement or concern from public health. So obviously we're all about protecting, patient safety. but I'm here also to keep my client protected and informed as well. So I love that you asked that question, because it's certainly not your job to follow emerging infectious disease, but if you are part of your water management team, making sure to get that person involved. Hi, Gary. I didn't know you were here. Nice to see you again. I like the goatee.
Thank you.
Yeah, and Madeline mentioned Burkholderia and infection preventionists being involved. A lot of times that emerging literature only comes through the people that have access to those literature sources. And we see these organisms that are associated with water systems are also associated with some pretty bizarre things like contaminated hand soaps, where something we're expecting to make things better is actually a potential source when we're looking at an outbreak. So it's really important to have those other professionals involved.
Yes, and sometimes, the infection prevention, they reflexively go to water. Water is the source. And it's important to have someone on your team who understands that there are these other potential sources, right? And not everything grows and amplifies and thrives in the same environment. And it also cannot be cultured. Sampling and collecting environmental samples versus collecting a clinical sample from a patient, really different process. I'm sure I see a lot of you nodding your heads. It's like a long process. And some of these organisms are really slow growers, really difficult to grow in a lab. And so during an investigation, you may never get a positive. You just implement a bunch of controls and the cases go away. And it can be a very long, frustrating process.
Is there any other questions?
Angel, this is Gary. I'd like to just make a quick comment again. John and Madeline, really nice presentation. I so value you guys in your approach and, and kind of a balanced approach. I just want to emphasize that if there's anybody that doesn't have a good water quality management program in place, please don't make, and Shane, you were absolutely right. I think there's more and more precedents being set to test for Legionella, but don't make just going out testing for Legionella your first action out of the gate. That'll get you in so much trouble. And there's so many things that you could be doing and should be doing first. And like John said, it's part of that risk assessment. And I think we're just watching the trend as this continues to escalate, that, it depends upon the risk assessment, but don't ever forget that it's the attorneys out there that they'll give you a risk assessment of your chances of winning a case. But if you ever do cause a problem, it's a zero risk environment. So you've got this balance that you've got to very carefully go through. And I don't recommend doing this by yourself. I so agree with John, that you've got to have some help with this program.
Yeah, I agree with you, Gary, that you can't just jump into this, start testing and find out you may or may not have issues. I'm good. Any other questions from?
There was a question about chlorination from Anthony.
Okay.
Yes. Hi, my name is Anthony. I'm the plumber here at UCI Medical Center in Irvine. So I have a question regarding the chlorination, more or less the time they chlorinate in new construction. So typically, and I'm coming from a contractor, I used to install a lot of these new systems in hospitals, a lot of TIs where you're building in existing systems and tying into their plumbing. And one of the things we do is right at the point where we put our finish in. So we got all our faucets, our drains ran. We pump the system up with chlorine, chlorinate it, flush it out of the system. What I've noticed now that I'm on the maintenance side, I'm on the other side of that system will sit there and sit for up to a month or more at a time with virtually no use, because most of the construction has been done. There's a little odds and outs that they're finishing up. That's like dealing with hanging stuff on wall, filling in spaces. What is something I can do to, because I know they need the chlorination for the licensing. So how do I stall the chlorination until it's a more appropriate time? Say, it's only a 3-hour event. We know they're going to come in tomorrow. Let's hyperchlorinate the system the day before or 2 days before to have a little bit more effect.
That's a really good question, Anthony. And I would go back to that WICRA permit that Madeline showed from ASSE. We've seen buildings where the system was energized and commissioned and it didn't get occupied for 11 months. and it sits there stagnant and stuff grows, and it happens. It has happened. What should happen is now we're a lot smarter. We bring the contractor in, the builder into the risk assessment process for the construction project, and we talk about the water systems. What does the owner expect that water system to do? And if it's going to sit for a month, you're going to chlorinate to whatever parts per million for whatever period of time. What's going to happen in the interim before you get to take ownership of it? And that should be defined at that time. You mentioned a couple of different things. They could come in and they could hyperchlorinate right before. Those are all options on the table, but it should be discussed before the construction project so they know ahead of time what the expectations are, and everybody knows that that system is going to be turned over to the owner healthy and in alignment with the plan to manage it.
So I've already talked to planning and a lot of the contractors that work here about it, and even our own IORs we have here. I can't seem to still, like, they still insist on chlorinating as soon as they can, just for the licensing reasons. And I'm kind of a small cog in a bigger machine, so I don't make a lot of movement here.
Well, they've got a commissioning process for their system that they have to meet, and that's not going to change. It's what happens between that commissioning process and you get to take ownership of the system that you've got to get modifications to occur.
So I think that's just working with wording and maybe having, because I would rather have them, they can chlorinate, but do flushes, regular flushes, either once a day or numerous times per week. Because chlorine is rather harmful for the system. The less I have to do that, the better. I just want the water moving in reality. So I'll probably work with them more on just getting that and saying, hey, you know, start adding into the bid a allotted number of hours to say flush the system when the system's installed after. But that's hard to say because you don't know how long the system is going to sit there and sit until we take ownership.
Yeah, that's a good idea. Here's just a reality. That's not something the contractors have typically done or put into their bid process.
Yeah.
So they're going to say, fine, you want me to go around and flush 22 faucets every day? Who's going to pay for it?
Mhm.
How do you expect me to document it?
Yeah, or you build a new tower and you don't open it up for 9 months because of licensing, you know.
And a lot of the times it can be hung up on something that has nothing to really do anything with the plumbing system. It could be a structural thing that is hung up, and that's why they haven't moved people in. So everything's quote unquote finished, but still just kind of just sitting there. And because we've had that where we've had a couple areas where we turn it over and EIP wants us to put it into our water management program because we've been running it here for now a few years. And so we'll test right after or right before occupancy, and we'll usually do like an HPC test, maybe with some Legionella, but we always get bad readings.
You know, Anthony, I put 2 references in the chat. I know we're a little over time. I'm happy to stay if people want to. I know, Angel, you know what would happen.
It's done. But go ahead, finish your statement.
So the AWWA C651, that's the disinfection of a water main. That's regulation, you got to do that. But ASHRAE 12 has good guidance on commissioning of new systems. Do not rely on the contractor to do this. They're just going to give you a report that says we flushed the whole building and the timestamps say they did it all in 15 minutes. And then when you do, I would recommend flushing with the flow restrictors removed, because you're going to flush out a lot of sediment and it's just going to catch in those restrictors and you're going to have reduced flow anyway. So you could be flushing every week, but you're not getting much flow because of the amount of sediment that's in there from the construction.
Yeah,
All right, I'm
depending
done.
okay. Depending on the contractors I get, I either get a lot of sediment or I don't get hardly any. But yeah, that's really depending on the contractor there. Because every time I install a new fixture, I typically flush the system, probably take about 2 5-gallon buckets worth out of each line just to make sure all construction dust is cleared, you know, if any ringing shavings gotten in there, whatnot. But that doesn't always happen, especially on the larger systems.
Well, good question, Anthony.
Thank you.
Conversation on the subject. Again, I'd like to thank you, John, and Madeline, for doing this presentation. Appreciate you all, and we'll see you next month. Everybody have a great
Thank you,
day.
everybody. Thanks for allowing us to come.
Yes.
Thanks for your leadership, Angel, in putting this together. And John, always great to see you.